Our first speaker for this afternoon is Dr. Gustavo Roman. Dr. Roman is the Jack S. Blenton Presidential Distinguished Chair for the Study of Neurological Diseases and Professor of Neurology at the Houston Methodist and Weill Cornell Medical College. He specializes in memory problems and dementia in the elderly. His clinical interest includes the evaluation and treatment of patients with Alzheimer's disease and normal pressure hydrocephalus. He is the lead author of one of the earliest papers on the impact of COVID-19 on the neurological system. So we are very happy to have him give us a talk today. And his topic today is the neurology of COVID-19. Dr. Roman.
Thank you, Dr. Lai. I would like to thank you and Dr. Appel for this very kind invitation to participate in this meeting. Reviewing the neurology of COVID-19 had very interesting surprises. The first one is that there are a lot of resemblance, a lot of similar points with the flu pandemic that 100 years ago affected the world. As you can see, it also affected the United States. You can see from these images that the caregivers and the nurses were wearing the face mask. Of course, that was the way to protect themselves from the pandemic flu of 1918. This has been very nicely described by Gina Colata, who was the science writer for the New York Times for many years. And in this book, she describes very nicely how this pandemic affected the entire world, the United States, and essentially disappeared from the public. Nobody wanted to talk about this for many years. And she said that perhaps as we grow almost snug about influenza, the most quotidian of infections, a new plague is now gathering deadly force. And she correctly predicted that something similar could be happening. And she said, and she's wrong, except this time we stand armed with a better understanding of the past to better survive the next pandemic. Unfortunately, I don't think we have learned too many of the lessons from the past. The coronavirus disease 2019, or COVID, is the official name for the disease caused by the novel coronavirus SARS-CoV-2. It's a severe acute respiratory syndrome, or SARS, caused, as I mentioned above, by SARS coronavirus 2. And it began in December of 2019 in Wuhan, China, and has now extended throughout the world. As of this morning, 28.5 million cases around the world, and the United States has the largest number of cases of any country with 6.7 million cases and counting. Regarding the total deaths, we will be close to 1 million people killed by this virus within the next few days in 188 countries and regions of the world. When you say that we have 197,000, it sounds a little void, but let me tell you that this is the equivalent of 1/3 of the total population of Boston, Massachusetts. So that will give you a sense of how lethal this disease has been. Also, 1/3 of all United States coronavirus deaths occur in nursing home residents and workers. Dr. Appel rightly so called this disease the silent executioner of people who have neurodegenerative conditions or amyotrophic lateral sclerosis and other conditions. So it has been absolutely lethal, especially affecting some of the patients that we see in our clinics in neurology. Let's go back till March of this year. Towards the end of the month, the 8-county Houston region was seeing a substantial increase in the number of cases, and the authorities decided to lock down the city and to avoid the contact in an effort to control the pandemic. At that time, working from home, we were not doing telemedicine yet. I had a virtual meeting with my colleagues at the environmental neurology group of the World Federation of Neurology. I was elected chairman last year. And I told them that it was probably a good idea to have some solid neuroepidemiological data on the extent of the neurological manifestations of COVID-19 around the world. This was following the example of the Spanish Society of Neurology that was facing one of the most severe outbreaks of the disease in Europe. But they designed a very simple method to go online to the society website and essentially report a case of stroke or Guillain-Barré or other conditions that had been occurring at the time of the pandemic. We published a letter in the Lancet Neurology and then this paper that was the result essentially of a very widespread search of the literature by my colleagues from around the world. And during these weeks of the close down, I was able to write down this paper that essentially provided what I can say is the first comprehensive review of the literature on the neurology of COVID-19. We reviewed the clinical manifestations and, of course, the acute respiratory distress syndrome and a very peculiar hyperinflammation syndrome or cytokine storm that occurs both in adults and in children. In children, it's called the multisystem inflammatory syndrome in children, or MISC. It was accompanied by acute cardiac injury, arrhythmias, cardiomyopathy, liver and kidney injury, hypercoagulability, problems with thromboembolism and pulmonary embolism in particular, and again, neurological complications. These neurological complications affected both central and peripheral nervous system. And for the central nervous system, all sorts of encephalopathies, sometimes seizures that occur de novo, vasculitis, stroke, both ischemic, hemorrhagic, and venous, hypercoagulability, meningoencephalitis, myelitis, and as I mentioned before, the Guillain-Barré syndrome, and in some cases of C. Miller-Fisher syndrome. There was also involvement of the muscle and the form of myopathy and rhabdomyolysis. After this publication, a number of papers appear in the most selective neurological journals around the world, confirming our initial presentation that indeed there were a number of central and peripheral nervous system conditions that occur in patients with COVID. There was also an increase in the number of psychiatric manifestations, in particular cases of psychomotor agitation, acute paranoia, hallucinations that were occurring in patients affected by COVID. So there is no doubt that the central nervous system takes a heavy load from this viral infection that is supposed to affect only the lungs, as was believed before. The coronavirus was a name coined by this Scottish virologist, June Almeida, who in 1967, working on the electron microscopy of the common flu, found these particles that have what she felt was the image of the solar corona. And she coined the name coronavirus from the Latin corona or crown. And now we all recognize very easily this spike image of the coronavirus. These are single-stranded RNA virus from the nidovirales family, from the genus coronavirus, and 4 genera, alpha, beta, gamma, and delta. Here is the phylogenetic tree. And in yellow, you will see the human coronavirus is OC43, and the alpha coronavirus is OCV229E, that we will find later on in the complications associated with the flu infection. Among the beta coronaviruses, there were a number of viruses that were isolated originally from the bats, from the pangolins, very closely related to SARS coronavirus 1 and SARS coronavirus 2, the current agent, as well as the MERS coronavirus from Middle East respiratory distress syndrome that was the agent of this outbreak. The viruses were originally isolated from bats, and from the bats they had intermediary hosts that were infected, and from that intermediary host they infected the humans. The reason why we were looking for bats in the markets in China is because both the bats and the pangolins are considered to be delicatessen, very fine foods. And once you take the bats out of their environment, they infected then this intermediary host. And from the intermediary host, they infected the humans. You have to think in terms of the resistance of the coronavirus to the immune system of this variety of animals, including the bats, the pangolins, the camels in MERS, and the infection in the man. So that brings us to the pathogenesis of this infection. These are, as I mentioned, single-stranded RNA viruses that have the longest RNA genome, about 30 kilobases, and three main viral proteins, the protein S from the spike, membrane protein, and envelope protein. But it is certainly the typical spike that is a glycoprotein S that mediates the entry of the virus into the host. It determines the range of potential hosts from pangolins to humans, the cell tropism, what type of cells, what type of systems are going to be affected, and they are going to determine the pathogenesis of the disease caused by the infection with this coronavirus. This is the spike protein, as you see here, is a trimer, but in isolation, one of the monomers have two main components. The S1 component called the globular receptor binding domain. There are points of fusion where the S1 globular receptor will separate from the S2, the stuck function, and this is the key element for the invasion of the virus. Once the globular receptor binding attaches to the AC2 receptor on the surface of the respiratory epithelium, then the protein is twisted and allows the exposure of the S1 and S2 cleavage sites so that the human transmembrane protease, serine-2, also known as TMPRSS2, can separate then the S1 from the S2 components, allowing the entrance of the virus into the host cells. Summarizing here, you have the respiratory cell membrane with the AC2 angiotensin converting enzyme 2 receptors. The S protein attaches there. The attachment exposes the cleavage side on S2 that is acted by the transmembrane protease serine-2 or TMPRS2. So these are essentially the two key elements in the pathogenesis of the infections that we have mentioned. For that reason, the pharmacologists and the pharmaceutical industry is busy trying to find the way of blocking either one of these two components, or the two, the AC2 and the TMPRSS2, in order to prevent the entrance of the virus to the host. Some of the proposals include the recombinant soluble AC2, the modulators of AC2, inhibitors of the TMPRSS2, but unfortunately, no effective virucidal agent has been found. Once the membranes fuse, the host and the virus fuse, the RNA of the virus enters the host cells, and in a way it hijacks the production of the proteins and RNA of the host cells, and then produces copies of the RNA of the virus and begins to build new viral particles that are assembled, and then once completed are eliminated, they exit the host cell to attack the neighbor cells or to go into the air to expose other individuals and produce the disease. It should be mentioned here that people who are taking medications that affect the renin-angiotensin-aldosterone system, the so-called ACE inhibitors and ARBs, should continue taking the medication because they really don't affect the ACE2 inhibitors and have no effect on the susceptibility of the infection. What seems to be important is that the circulating plasma concentration of the ACE2 enzyme is higher in men than in women, and that explains why the COVID-19 is more common in men than in women. When the concentration of nasal ACE2 levels in children is measured, these authors found that below the age of 10 years, there is practically no ACE2 levels, and that probably explains the fact that young children are essentially resistant to infection by the coronavirus. As we grow old, the concentration of the nasal ACE2 receptors increases. What about the transmission? Well, it has been known for many years that it is through sneezing, coughing, singing, talking that the virus is transmitted. Most of the heavier particles, so-called flugy droplets, fall to the ground and to the surfaces, and that's the reason why you see in many places that they clean the floors and the surfaces many, many times after seeing patients and so on, because the virus is deposited there. However, particles that are less than 5 microns tend to stay in a state of aerosol in the air and become infected. So that's the reason why you cannot leave your surgical face mask to try to prevent the infection by this virus. It worked in 1918, and it certainly worked today, although many people believe that it's an attempt against their individual liberties and so on. But the second point that was recommended 100 years ago was to wash your hands after you come to the house, here in the hospital, to wash your hands as many times as requested, and also the social distances leading to the closing of football stadiums and theaters and movie theaters. Once the virus reaches the receptor, then the disease progresses. Again, the ACE2 receptors are present in the nose and the lungs. The cells that are affected primarily producing then a severe pneumonia. The problem is that there are ACE2 receptors in the kidney, in the intestine, and in the endothelium. And this is probably one of the factors in the severity and the pathogenesis of the disease. Is responsible for some cases of stroke. And there are also ACE2 receptors in neurons and glial cells. So because of that reasons, once the olfactory cells are affected, there is a rapid entry into the central nervous system. This is the progression according to information provided here at Houston Methodist on the pulmonary progression of the pneumonia. And this is a paper by Dr. Susanna Varga and colleagues in Germany demonstrating on electron microscopy the presence of the viral particles on electron microscopy in the endothelial cells and the presence of an inflammatory reaction that they call endotheliitis that is probably responsible for a number of the activations of the immune system that are present. In particular, these lesions of the endothelium tend to affect the coagulation system, as reviewed recently in Blood, the Journal of the American Society of Hematology, and they demonstrated that there is a coagulopathy that develops as the increases in fibrinogen, D-dimers, with minimal changes in PT-BTT and platelet count. The increase in the levels of interleukin-6 is correlated with increasing fibrinogen levels, and the coagulopathy is related more to the inflammatory response to the infection than the actual intrinsic virus activity on the blood vessels. Elevations of D-dimer and admission are associated also with increased mortality. This coagulopathy, this tendency to produce thrombosis, is probably responsible for the cases of stroke with occlusion of large vessels that occurs in people younger than 50 years of age, as first demonstrated in New York, without any pre-existing vascular risk factors, diabetes, hyperlipidemia, carotid stenosis. These patients were essentially healthy and then developed occlusion of large vessels in the brain. This was confirmed by our own stroke group here under the direction of Dr. John Volpe, Dr. Misra, Dr. Chu, Rajan, Gadia, and the group at our neighbors across the street at the University of Texas Health Science Center in Houston, and the direction of Shan Savitz. They demonstrated that indeed there are ischemic and hemorrhagic strokes in these patients with a relatively high frequency. Other changes that affect the blood vessels include the acute hemorrhagic necrotizing encephalopathy, condition that an autopsy is characterized by the presence of these petechial lesions throughout the white matter and the demyelination. You see the lesion in the center of the vessel, usually a vein, and the loss of the myelin staining as you extend beyond the blood vessel, and the presence, of course, of an inflammatory component. This particular condition, the acute disseminated encephalomyelitis, has been associated very strongly with the cytokine storm. Very early in the disease, it was demonstrated around March that many patients with severe forms of COVID develop the equivalent of what is called the secondary hemophagocytic lymphohistiocytosis. Is fulminant multisystem damage that occurs usually triggered by viral infection or sepsis. These patients have an unremitting fever, cytopenias, increase of iron, pulmonary involvement, and it occurs in about 50% of patients with these severe infections, including sepsis. The cytokine storm that is seen with COVID-19 also produces an increase in interleukin-2, interleukin-7, granulocyte, colony-stimulating factor, interferon gamma, inducible protein 10, monocyte chemoattractant protein 1, macrophage inflammatory protein 1 alpha, and tumor necrosis factor. This led to the use of, to a clinical trial on the use of dexamethasone in patients with severe forms. This is a report published in the New England from the UK, and they demonstrated that the use of dexamethasone decreased the mortality by 0.64% compared with usual care in patients who require invasive mechanical ventilation. However, when the dexamethasone was used early in the disease, when the patients require no oxygen, the mortality actually increased. The ratio increased to 119, indicating that, as reported by Dr. Appel in his opening lecture, the immune system is required to control the infection in the early phase, but once things get out of control, then the use of the dexamethasone is probably indicated. Let's address now the issue of the SARS coronavirus 2 neurotropism. One of the striking features of this pandemic is the severe mortality that has occurred, especially in places where there is very little support for intensive care unit, even medical support in some countries, as demonstrated from the first months of the infection, for instance, in the city of Guayaquil in Ecuador, where after the first couple of weeks, the army had to send patrols to pick up the dead from the streets because they had no way of finding a place for these people who had died. Something similar occurred throughout Brazil that, as you know, has seen a very severe outbreak of the disease, prompted in part by the fact that the directors of the country believed that this was nothing more than a little cold. Looking at the figures from China and the entire world, 81% of all cases of coronavirus infections are benign. They produce a little bit of difficulty with fever and sensation of malaise, but in general they improve completely. The problem are the remaining 20%. In those cases, when they require admission to the hospital, the case fatality ratio goes from 8% to 14%. And once the patients require intubation and respiratory support, the mortality can be as high as 49%. We have learned from our colleagues in intensive care unit that they usually can handle the most severe pneumonias without significant mortality. But in this case, this was behaving in a different way. And we felt that perhaps one of the reasons was the fact that the virus could be affecting the respiratory and cardiorespiratory centers in the brainstem, and this would explain the dismal prognosis of the disease in these very severe cases. Some of the problems associated included the so-called the mystery of the happy hypoxia. These were patients that arrived with the hospital with very low oxygen saturations, but didn't feel any difficulty breathing, any shortness of breath. And this was also considered to be by the neurologists a lack of dyspnea as part of the neurological conundrum of this interesting disease. So let's see if we can demonstrate some of the neurotropism of the coronavirus. In general, most of the coronaviruses that affect multiple species produce just either respiratory or enteric diseases that are mainly of veterinary interest. And only the exception is the encephalomyelitis coronavirus in pigs that was isolated in several of the rodeos around the country and in Canada. But other than that, the only other virus, coronavirus, that has clear neurotropism was the mouse hepatitis virus that produced lesions in the central nervous system that appeared to be close enough to multiple sclerosis to essentially be used as a model of multiple sclerosis in animals. Two of the viruses that I mentioned earlier, the human coronavirus OC43 that produces a common cold, has been found at least in 2 reports of acute disseminated encephalomyelitis in a teenager and encephalitis in a young immunosuppressed boy. And these 2 viruses, the coronavirus 229E and the OC43, have been found in up to 36% of the brains of patients with multiple sclerosis. This is a work of Dr. Nathalie Arbour and Pierre Talbot and colleagues in Canada that demonstrated that when you look for the presence of the virus using reverse transcriptase PCR in brain samples from either normal patients or patients with other neurological disease or patients who had confirmed multiple sclerosis. These are samples that were obtained from the famous Salpêtrière Hospital neuropathology laboratory in Paris. And they demonstrated that up to almost 36% of the patients with multiple sclerosis had this virus. But also they are present in normal brains, suggesting that perhaps some of the severe headaches of some common colds may actually indicate that the virus is actually advancing into the brain, but then it's controlled and stays there until you die. So in general, the coronaviruses were considered to be the agents of the human flu, were benign pathogens until 2002, when the first epidemic occurred in Guangdong, China, due to the SARS-CoV-2 with a mortality rate of about 9.6%. 12 years later, in the Middle East, in Saudi Arabia, cases of a severe respiratory syndrome called MERS, Middle East Respiratory Syndrome, due to the MERS coronavirus, occur in Saudi Arabia, and they are still present. In December of 2019, then the current pandemic occurred due to SARS-CoV-2. coronavirus 2. The symptoms that suggest neurological involvement include the presence of headache that ranges from 6% to 13% of all patients, much more higher in patients who end up having stroke. The presence of agitation and delirium, especially in ICU patients, that was reported in France, occurring between 65 and 69% of all patients in ICU who become agitated, with presence of the Babinski sign, brisk reflexes suggesting involvement of the pyramidal sign, 65 to 69% of those patients. Of course, alteration of consciousness that occur in 22% of fatal cases compared with only 1% in non-fatal cases. And most interesting, the presence of loss of olfaction, anosmia or hyposmia, and the loss of taste, dysgeusias, that occur between 85 and 88% of the cases. So it's quite a common feature in the initial phases of the infection to complain of loss of taste and loss of taste. A very interesting report was this patient who is a radiology technician working at the MRI lab in France, who in Italy, who presented with symptoms of acute coronavirus infection. She had the fever and she had the loss of olfaction. They did an MRI of the brain, and sure enough, you see the two olfactory bulbs being affected by the infection, as well as the gyrus rectus. You see them more clear here. And these changes disappear as soon as the anosmia disappear in the patient. So it's an indirect evidence that the virus has been able to actually attack the central nervous system. This study from the United States demonstrated that there are genes that express both the AC2 and the TMPRSS2 proteins that are required for the entrance of the virus, and they can be found not only in the neurons but also in some of the support cells, the stem cells and perivascular cells in the olfactory system. Of great interest also is this paper where they infected with the SARS coronavirus 2 the human brain organoid model, the so-called brain in a dish. And they demonstrated indeed that the virus thrives in this model of the brain. It affects especially the red endoplasmic reticulum, the cells that you can see here infecting the ribosomes and the system that produces proteins and nucleic acids in the host cells. So the cells thrive in the nervous system. And these are the highways that are proposed as the entrance to the virus. Of course, the olfactory nerve, cranial nerve 1, as we mentioned, through the olfactory filaments to get into the olfactory bulb, the sensory fibers for the eye, the cornea, the mouth that go to the trigeminal ganglion, the taste in the anterior third of the tongue through the chorda tympani of the facial nerve, the glossopharyngeal, and then in the vagus nerve also for sensation in the posterior portion of the throat. These pathways of infection were nicely demonstrated by this wonderful study from the famous Charité hospital in Berlin, in demonstrating that when the patients undergo a careful neuropathological autopsy, these authors were able to collect material from the olfactory epithelium in the nose, the olfactory bulb, the cornea, the uvula, the ganglion, the Gasserian ganglion, and the brainstem nuclei. And as you see here, they were able to demonstrate the presence of the virus in the olfactory mucosa, the olfactory bulb, the conjunctiva, the cornea, the uvula, the trigeminal ganglion, and the medulla oblongata. So these pathways do occur with the infection of the virus, particularly in these patients who died from the disease, probably indicating either a massive infection initially or changes in the immune system. You can see here in this diagram the structures of the olfactory mucosa with the ciliated columnar epithelium, the bipolar olfactory receptor neurons with dendritic extension, the presence of Bowman mucous glands, the lamina trigemina, and then the fibers that form then that go into the olfactory nerve. When they did the same study, you find in blue the epithelial cells, and with the brown staining, oblique 2, the olfactory neurons. In this staining, what we are seeing is the pancytokeratin marker, but you see very clearly the olfactory neurons. And you can also see in the next slide the presence of the SARS spike protein, the S protein in brown, affecting a large area of the olfactory epithelium and also the perivascular spaces. You see here the vesicles at the end, dendrite tips of the olfactory receptor neurons, and on their electron microscopy, the now typical appearance that you clearly recognize of the coronavirus affecting these patients. Another neuropathological study from Germany also demonstrated that in patients who die with coronavirus, if they are younger than 65 years of age, the cerebral hemorrhage, bleed, and complications with thrombosis are the most common cause for that. But in all patients, regardless of age, they found a perivascular interstitial encephalitis with neuronal cell loss and axon degeneration in all these brainstem nuclei that we just mentioned: the dorsal motor nuclei of the vagus, nucleus of the trigeminal nerve, nucleus tractus solitari, the dorsal raphe, fasciculus longitudinal alis medialis. And it's interesting that they rule out the possibility that some of these lesions were the effect of hypoxia. The parts of the brain that are susceptible to hypoxia were not affected. So this was just direct neurotropism and invasion of the virus. You can see here a larger magnification, the perivascular infiltrates, the neurons that have been affected and are about to die, the presence of inflammatory cells. Here is a leptomeningeal vessel showing also the inflammation, and at higher magnification, the same, the presence of damage to the neurons and the presence with immunostain of inflammatory cells. So it seems clear that the virus is neurotropic, that it contributes to the large fatality, especially in severe case, and that these are the pathways from the cranial nerve to the olfactory, in the olfactory mucosa, the ACE2 receptors, both in the nasal mucosa and in the nerve fibers. They go through the olfactory tracts to the rhinencephalon, and this could be the explanation for the severe delirium and psychomotor agitation that has been described in these patients in ICU. The sensory nerve fibers in the nose and the mouth, in the cornea and the conjunctiva, that then progress to the Gasserian ganglion and to the trigeminal nucleus in the brainstem, and through the facial nerve for taste in the anterior 2/3 of the tongue, through the chorda tympani to the pontine geniculate nucleus. The glossopharyngeal is in charge of the taste in the posterior third of the tongue, the oropharynx, and also in the carotid sinus. So during the endothelial invasion, it is conceivable that some of these virus will reach the nucleus tractus solitari, and there are cases of oropharyngeal dysphagia with paralysis of the swallowing due to the viral infection. Finally, it has been postulated also that the numerous chemo and mechanoreceptors that are present in the lung could be affected during the severe pneumonia, and the virus will go through the vagus nerve, through the nucleus of the vagus and the nucleus ambiguus. So a very massive attack of the nervous system produced by this virus. What do we have in terms of prevention? Well, as you know, 2 or 3 days ago, STAT published this report indicating that AstraZeneca and Oxford, who are in the front line of the Operation Warp Speed for the vaccine, they use a chimpanzee coronavirus mixed with a vector from adenovirus. was having excellent results in terms of induction of the antibodies against the virus, but they stopped the trial because of a patient who had an adverse reaction in the UK. 2 days later, or the next day, they gave us the diagnosis of transverse myelitis in one of the participants. Apparently, the patient recovered well with the treatment, but it's worrisome that for the vaccines, we may have also side effects that affect the nervous system. And this brought me back to something that occurred when I was a senior resident in Burlington, Vermont. During the 3 years of my training, I had seen 2 or 3 cases of Guillain-Barré syndrome, and all of a sudden, after the campaign for the swine flu vaccination was started, we saw 3 cases in a week, indicating that something was happening, and all 3 patients had received the swine flu vaccine. You may remember that this was the result of a fatal case in a soldier that occurred in Fort Dix, New Jersey, probably the same area where the 18 flu pandemic started. It was considered to be an infection that jumped from the pigs to the humans, and the experts were afraid that we were going into another pandemic of the flu. They decided to create a vaccine against the swine flu, and President Gerald Ford was the first one to receive the injection, and about 25% of the population of the United States received the vaccine. The problem is that cases of Guillain-Barré started to appear throughout the country. In total, 743 claiming 325 million. The company that produced the vaccine, of course, had signed a contract with the federal government indicating that they would not be responsible for side effects or damages from the vaccine. So you and I paid from our taxes these claims. There were a total of 3,917 claims for $3.5 billion in damage. Not all of those were accepted. But when the judge, the federal judge that was trying to decide on what to do with these cases, he appointed a panel of experts that include not only that our own chairman, Dr. Stan Appel, Len Kurland, who was a famous epidemiologist from the Mayo Clinic, and Dr. Clark Millikan from Ohio. And they essentially were able to determine which cases were real and which cases had to be paid, and all 122 cases settled out of court. So in summary, we have seen the fact that neurological manifestations of COVID-19 could be present from the first symptoms of the disease, especially the loss of taste and the loss of olfaction. Encephalitis and myelitis may occur, as well as acute disseminated encephalomyelitis, Guillain-Barré syndrome, cerebrovascular disease, and these are either the results of a direct viral infection, the so-called para-infectious complications, or later on post-infection complications, and of course, the large involvement of the vascular system. As you see, there is a complete silence regarding what is going to happen with the long-term complications. I would like to propose to you that sleep disturbances may be expected and that we need to be ready for the potential of these infections. Already the Washington Post in September 3rd was saying that the pandemic is ruining the sleep, and this coronasomnia could impair the public health. And this reminds us of another complication that occurred 100 years ago of encephalitis lethargica after the flu pandemic of those years. Later on, we have found that a number of these neurotropic viruses, the influenza, are accompanied not only of the Spanish flu pandemic, but also during the Asian flu of 57-58, cases of Klein-Levin syndrome, and during the influenza pandemic in China, 2009 and 2010, narcoleptic syndrome were described. And the interesting thing is that the murine model of H1N1 flu infection that requires infection of the virus through the nasal mucosa of the mouse produces in all the animals narcolepsy-like syndromes. And the virus, of course, you guess it, goes to the olfactory nerves, to the olfactory bulb glomerular layer in day 14, mitral and glandular cells on day 28. And finally, through retrograde invasion, they affect the orexin and melanin concentrating hormone nuclei. And from then, they affect the lateral hypothalamus, damaging the control servo mechanisms for sleep. And finally, they go to the pontine dorsal raphe and the nucleus ceruleus nuclei and are responsible for some of the extrapyramidal manifestations. So we probably will have a repeat of the encephalitis lethargica described by Konstantin von Economo in 1917. And many of those cases survived the pandemic and were in institutions such as those reported in New York by our colleague, the late Oliver Sacks, who wrote Awakenings, that was followed by the movie with the late Robin Williams and Robert De Niro. And this is essentially something that we probably need to be aware of because it may affect our patients given the fact that they follow the same pathway that was followed by these other viruses at the time. So in summary, this is the PPE from the 14th century during the Black Death pandemic that killed and affected 50 million people throughout the world. One of the advantages of this equipment, of course, is that you are fully insulated, but they also put aromatic products in the back here so that you can have some therapy, some aromatherapy when you are working with your patients. Things haven't changed much, as you can see, since the 14th century, and we are still at the same, using the same principle to defend ourselves from the infection. It is important that we continue trying to avoid the infection because, as I mentioned before, we don't have an effective virucidal agent, and we're just beginning to understand what are the steps that need to be taken for the appropriate treatment of this condition. So many thanks for your attention, and please stay safe. Thank you very much.
Thank you very much, Dr. Roman. Okay, we still have a few minutes. We're waiting for questions. While we have time, can you share with us, now there's certainly a lot of talk about vaccines. What's your view on vaccines these days with all the information coming out?
Yes, I think it's absolutely critical that we have a vaccine. As I mentioned, from the swine flu pandemic, that created a movement throughout the United States and the world that vaccines were not that healthy. So it is important that during the trials, this enough number of subjects are vaccinated, number one, and number two, it is important to make sure that the possible components of the vaccine that may have cross reactions with neural tissue are avoided. You may remember that this was tried for one of the vaccines for Alzheimer's disease that produced a number of encephalomyelitis cases, and they had to go back to the drawing board and eliminate some of the potential components that had cross reaction with myelin basic protein in that particular case. So we need the vaccines quickly, of course, but it's going to be very difficult to get full coverage of all the people throughout the world who are affected by this problem.
We have one question. Can you take a look and read that? Can you read that, Dr. Roman?
Yes, the question is the following, very interesting question. I hear two different information about the loss of smell. Some of them permanent, others saying that it is temporary. Some of my patients currently in rehab for more than 3 months still complain of loss of smell. I would like to hear about your comment. Um, well, again, there are a number of factors that we don't understand in terms of the defense against the virus. Either because you have a genetic makeup that makes you very resistant to the virus, that you are able to mount a very energetic initial response, as seen in that example that I show you of this young woman who had temporary anosmia and who had, without any doubt, involvement of the olfactory nuclei of the olfactory bulb. But there are other patients where this is not present. Also, potential cross-reactivity with previous coronaviruses certainly could explain why some people respond well to the infection and control the problem, and other patients do not regain the sense of smell. However, if that's the only isolated finding in the patients, then it is a blessing and indicates that although some damage occurred in the battle, they were able to control the progression of the virus to the more central component of the nervous system. So we still don't know, and these are some of the questions that we have. And part of the reasons to encourage the formation of these data banks of complications, neurological complications of COVID, would be for later analysis to determine exactly what is the natural history of this problem. But thank you for your question.
Next, we have another question, sir.
What are your thoughts about the long-term neurological sequelae of COVID-19, similar to the 1918 swine flu? It depends on what sort of neurological sequelae are we dealing with. For instance, if a patient suffered an ischemic stroke because there was a temporary increase in thrombosis and increase of the D-dimers and fibrinogen, and that was controlled after the virus was until the acute infection was controlled, then the patient is going to have essentially the same prognosis that you have in other patients of the same age and the same vascular risk factors and profile that have suffered from large vessel strokes. The problems are those patients that have complications that result probably from the invasion of the virus in the central nervous system. In those cases, it is conceivable that the recovery is not going to be as effective. Patients who have pictures of encephalomyelitis, who have difficulty returning to normal cognitive level, in those cases, probably the prognosis is much more severe. Once this virus stay in the brain, in comparison with what happened in the 1918 swine flu, again, the complications were extrapyramidal syndromes, Parkinsonian syndromes, and the lethargic encephalitis, the different types of effects that they suffer from the damage of the central control centers for the sleep. In those cases, then it would be the treatment with the usual dopaminergic agents in an effort to control the dopamine deficiency that is seen in those cases. We are a little bit better than what we were in 1918 in terms of the treatment of these problems of sleep and the problems of the extrapyramidal system. But again, it's going to be a long time before we can actually determine what is the real natural history of neurology of COVID-19. Thank you for your question.
We have a few more questions, so we appreciate some short answers from you, Dr. Roman, on this one.
What are your thoughts on how long the virus could live in body, maybe at low level? It's a difficult question, essentially because it depends on where the virus is located. If it is in the respiratory tract, it can probably stay there for some time. There are now reports of these subjects who managed to contaminate a large number of people because they are asymptomatic, and 2 or 3 months after the test was diagnosed, they continue to have the virus. They are continue to be carriers of the virus. So that's one more element in favor of, we need to have a good virucidal agent that will be able to eliminate those cases of asymptomatic carriers. How long they live is not very clear. The antibodies apparently last about 3 to 6 months.
We will have one last question. Sorry that we could not answer some of the other questions now, but how about this last question, Dr. Roman?
Is there residual scar tissue in the nervous system and lungs that remains problematic? I don't know about the lungs, but it's very likely that some changes will remain there. Regarding the central nervous system, the usual scar tissue in the nervous system manifests usually as seizure disorder. And there have been relatively very little publication regarding the presence of persistent seizures in those patients, but it could be one of the changes that are seen. The others are changes in behavior and even dementia in some of those patients as a result of the damage in the brain, especially if the tissue is already damaged by a neurodegenerative process. Thank you for your question.
Thank you very much, Dr. Roman. I appreciate your excellent lecture. Oh, thank you. So let's go down to our next lecture.